Good evening, friends. I'm Dr. Vijay Agarwal, and as President of Consortium of Accredited Healthcare Organizations, so along with CAHO and Ayushman Bharat, we welcome you to this very important webinar, I think, on a very important topic as to how to communicate with patients. Communicating with patients had always been a big problem for the healthcare workers and has been very well recognized. But in this current pandemic, I think the degree of the problem of communication has multiplied. How many times maybe we listen to our experts? I don't even hazard to guess as to whether it is 10 times more or 50 times more. What I feel is that even the best in the field are struggling to come out with guidelines as to how to effectively communicate at this juncture. And this is really a big, big problem. And to address this problem, really, do we need a special infrastructure? How do we kind of communicate with our patients? And how do we communicate with our staff? So on these three very important, I would say, subtopics, we had to, I think, get the best in the country to come to this battlefield and to guide us all as to how to have an effective communication. And we have Dr. Lallu Joseph as the opening bets person. She's going to address as to do we need what kind of changes in the infrastructure. And then we have the king of communication, Dr. Kingsley from the Baptist Hospital. We have heard him, I think, over the last so many years. He has been the pioneer in bringing about, I think, revolution in creating trainers for the communication in the country, along with Dr. Badri Datta. So Dr. Kingsley will be, I think, telling us about how to kind of go about talking to the patients. And then we have one and only Dr. Sanjay Singh, who is the rock star and the head of the Amrita Institute. And he will be telling us how to make an effective communication with our staff. So I'll not like to stand much between you and these illustrious speakers. So over to you, Dr. Lallu Joseph. She is the head of the quality and almost the chief of the CMC Vellore, and of course the Secretary General of CAHO. Over to you, Lallu.
So thank you very much, sir. I think that was over exaggerated. I am an employee of Christian Medical College, Vellore. That I would call as an exaggerated communication, but thank you very much for that. So I'm going to talk about how we are going to communicate through the environment that we are in. Basically, it is the infrastructure that I'm going to talk about. Is my screen visible, sir?
No, ma'am, you have to share.
Yeah, just a minute. Yeah.
Yes, now it's visible.
Yeah. So that's going to be my talk on how the infrastructure, how the entrance of the hospital, how the personnel in the front desk, how should they be communicating during this pandemic. I don't think I need to go in depth into this aspect, but I thought I'll just bring in some perspective with some pictures as to how we are actually communicating at the moment, how best we can do to try and communicate effectively. Now, as you all know, we talked something about what is known as the healing architecture. Florence Nightingale is the pioneer in that, a visionary in understanding the environment and the impact on patients' health. And she is the pioneer on the concept of healing environment. And her notes on hospitals in 1859, she wrote, the adjustments in the environment, how it can avoid illnesses. And creating an environment physically healthy and also psychologically appropriate can really go a long way in the healing process for our patients. And it indirectly contributes to the patient's outcome reduce length of stay, reduce stress, increase patient satisfaction. So these are all very well proven. So we have basically gone ahead and designed, or rather in the last 15-20 years, we've spent a lot of time and efforts in creating our hospitals to suit this healing architecture, or to create an ambience that is effective so that we have increased patient satisfaction, to reduce the stress. And in some hospitals that I have visited, you don't even get the smell of the hospital. You don't see any pictures or any anatomical pictures anywhere. So it is basically to create an environment that patients feel that they are not in a hospital environment. But however, with this pandemic, it's really taken a turn in the other direction. Patients are scared. Forget about patients. The healthcare workers are now scared to get into the hospital. It is kind of a doomsday atmosphere that we create in the hospital. It is panic all over the place. I honestly feel that every time I get into the hospital, a feeling of, a paranoia, a feeling of scare, a feeling of fear is what comes in when you enter into the hospital. For healthcare workers, if this is the feeling, think about the patients who are coming there. Forget about just the COVID patients. It's not just COVID alone. There are patients coming into the hospital who are sick, who will need some consultation, who probably will require a chemotherapy, who will need a dialysis. And the kind of fear that we are instilling in our patients is really far too much, is what I feel. Now, what can we do? These are some of the things that we have come into, accepting as a norm in the last 2 months. All mandatory for all patients and visitors to wear masks. It's mandatory for everybody now. Leave alone all of us, finally, President Trump has started wearing masks. Now, flu clinic at the entrance of the hospital. And that's like with the astronaut suit, people sitting there, hazmat suits, and it's a very scary environment there. And the patients are screened with thermal scanners. Imagine somebody pointing at you with a small scanner in their hand, and this is a security guard. In most places, it's the security guards with the thermal scanners in their hand. And then there is this concept of containment area screening, which is you with a checklist asking patients, where are you coming from? Now, if you are from a containment area, then you are treated differently. You are taken to another area where your OPD is run in a different area. And everywhere, all staff walking around with full protection, PPE in the ED, flu clinics, wherever. Now, the other thing is visitor restriction. Now, you have an inpatient who's admitted, visitor restriction all over. One patient visitor is allowed. And if it is if your hospital is admitting COVID patient, no visitor allowed at all for that particular patient. Now that patient is already in stress. How do we manage that? Separate route for everything. Green zone, orange zone, red zone, separate route, separate lifts, and all signage all over the place. So you are constantly watching out for signage as a patient, whether to walk in this route or that route, somebody is stopping you. So it's a scare that we are creating in the hospital. Do we need to do that? Yes, definitely we need to do that. Do we need to do that the way we are doing? I think we can probably do it a little better. We can become a little sensitive to these patients who are coming in with a lot of fear and scare in their mind. Now, imagine a situation like this, a flu clinic at the entrance of the hospital. Now, all of them are wearing masks. N95 almost covers your entire face and your caps, your entire attire. How does a patient even know who that person is who's sitting there? Now, as you enter this place, enter the hospital, this is the first thing that comes into your purview. Now, how can we make this place a little better? So before your patients come in, you can give them some kind of instructions that this is the place that you're going to go into, and this is the kind of screening that is going to happen. You can have screens demonstrating, you can put up some pictures, you can put up television screens explaining. And in some hospitals, I've heard that there is prior appointment to even coming here. If you're doing that, you could instruct your patients that this is going to be the norm. You enter in, you're going to have these kind of people sitting there waiting. You need to go through this process of going into the flu clinic. There will be doctors, there will be nurses. So some amount of instruction, some amount of communication with your patients will help in allaying the fear of your patients. Now, this is the second thing, screened with thermal scanners. And this practice, we have not trained our staff well to do this at all. So they point this particular gun onto the, the patient's forehead. It is actually very scary. If some of you have gone through that, I don't know, it just points there, and it is really scary to go through that. But I think it's become the norm. Most of us have got used to it now on a daily basis. But I think it is important to just give a small smile. We always feel that with the mask and other PPE that we are wearing, our smile is not visible. But yes, the eyes give the smile out. So it is good to even teach your security staff and the front office staff to give a smile so that your eyes show that smile. And also it is good, as I mentioned earlier, to give some kind of communication to your patients who are entering that they are going to be screened with this particular thermal scanner. Now coming to ED. Now this is a very, very scary environment. Full protection, complete PPE. Forget about even the flu clinic, it is only part PPE. But when you come into your ED or other clinics, it is like complete suit that they are wearing. And many of them don't introduce themselves. You don't know whether that's a doctor or a nurse, first of all, who's sitting there. So some places, what they have done is they have put the picture of the doctor who's sitting there just like this. I mean, I think this is a very good practice to have it also. Picture of the doctor with the name and the designation maybe. And also to introduce before you start the conversation with the patient. Believe me, smile matters. Your body language actually changes when you smile. So we think with this PPE, are the patients going to notice the smile at all? But definitely yes, because your entire body, the way in which you smile, the body takes it, and your posture also takes a turn when you smile. So it is good that you encourage everybody to smile. They will also be in fear. But yes, all your staff should be trained to smile. So interestingly, this has made a major impact, putting the picture of the doctor with the name, all that has created a lot of, allaying the fear of the patients. It has really helped is what, there are studies being conducted on this, and that says very clearly that really helps in taking away the fear of the patients. Entry restriction is another thing. Too many signage everywhere. I think we just need to avoid these kind of signage in all these places. Yes, we can restrict the entry in better way. Too many signage clearly clutters the place, and people don't read it also many a times. But yes, it creates a sense of fear when they read that. So it is best to have these, the routes and other things put in such a way that you don't enter into these areas at all. Avoid signage to be too much of signage. That's how I should put it. Now everywhere, lots and lots of signage everywhere. Caution with this COVID signage, things hanging all over the place. I think we should avoid, and every department is putting up. It is not one department in the hospital that's taking care of the signage. Doctors, nurses, departments, everywhere, everybody is putting signage, stickers everywhere. So in the end, you will see only signage all over the hospital. Visitor restriction is definitely needed, but we tend to, forget about this restriction concept that the patients who are admitted also need some amount of help. So you will need to create some amount of help desk, maybe some video talk with the relative, with the patients of the other relatives, maybe the loved ones. They will need to have some amount of communication established. We feel that, the mobile phones are available now. So, the patients can always communicate with their relatives. That's not what it is. I think we have to go an extra mile to create help desk. Some of them may want to supply some biscuits, some cakes or some bananas to their relatives who are admitted. We will need to create help desk so that we kind of help the patients who are admitted, particularly into these COVID wards, have what they need. Otherwise, most of their patients' relatives are in quarantine, and the extended relatives may want to give some kind of support to these patients who are admitted. So it is very important for us to provide that kind of helping atmosphere in our hospitals. Food and refreshments, yes, the canteen that we have, we try to keep it very clean, social distancing, all that. But we expect our patients to bring some kind of mugs and cups to collect coffee and collect drinks and all that. It's okay once in a while to compromise on environmental aspects. at least we can go in some kind of, use and throw containers or some paper cups and all that, because the situation is such that we need to support our patients and relatives who are coming in. I think it is okay to compromise a little bit and use some use and throw paper cups and all that and provide. I have seen hospitals that are being very, very strict with this, bring your own cup in such a situation, when they don't even have relatives to be really walking around multiple times, collecting some mugs from outside, shops are closed. So we need to basically create that ambience, a helping atmosphere to our patients. Social distancing, these marks are everywhere now, and nobody really wipes them also. So people get confused, one counter is created in one area, one social distancing mark is put there. After that, the counter is moved somewhere else, and still the social distancing, all these rounds are all over the place. So be very cautious about that, because we are really creating a sense of, we are not really being careful about the needs of the patients. And this is another thing, patients are made to get up, because every 1 hour there's an announcement that is coming, get up, wipe the tables, wipe the chairs. So these are very impersonal. So when patients and relatives are sitting there, we are making them get up and clean the tables and chairs so that our housekeeping staff have that place available for them. Let's become a little more personal and try and see when the relatives, when the patients are getting up and going, that we wipe that place. Rather than making some kind of announcement every 1 hour and making sure that the entire area is cleansed and cleaned. Spraying, disinfecting. This is another thing, whether it is needed at all. But we keep doing this because some of the government, state governments request us to do this. Now, when we do this, we just go in every area and start spraying. We have to become a little sensitive to the needs of our patients and the relatives who are waiting in all these areas. Make sure we do it in the evening times or in the morning times when the rush hour is not there. And make sure that we do it in such a way that we are being very personal to the needs of our patients, so that the smell is not all over the place. And these are things that are happening in many hospitals today. Hand wash stations are provided, but we don't tend to wipe them, clean them properly. Morning patients come in, and then that place is kept very dirty. Yes, too many posters everywhere, too many signage everywhere. And now today everybody knows. So I think we have to be a little careful about those things. We need to instill the thing that people will have to wash and come. But how we do that, do it in a very nice manner, make announcements, teach them, have the television screens, putting up these 20 seconds, how to wash their hands, all that. But don't overdo also. I think we have to draw a line as to where we want to be. So this is another thing which is extremely scary. I think we have to actually educate the patients before they go in for the swabbing as to what to expect. Many of them are very scared when they go in, and then, the people who are inside are not able to communicate. And the ones who are standing outside literally run away when the swab is taken. So we need to become a little more personal and try and tell our patients before they go in for the swabbing what to expect, how to do it. And these kind of things are very good to conserve PPE. But however, I mean, if we lose that patient, I think it's not the right thing to do. We shouldn't be creating that kind of, fear in the minds of the patients. So I would like to end here. It's a tough time for all of us. I think we just need to continue to learn, because last 2 months back, what we talked is totally different from what we are talking now. So we need to continue to learn from the mistakes, from our practices in our hospitals, so that all of us become better in what we are doing. And I'm sure it's a matter of another few months that we all come back to our normal routine and talk about a healing environment, back to our ambience, and try and communicate better to all our patients and relatives, and to our staff also. Thank you very much, Vijay sir, for this opportunity.
Thank you, CAHO and Dr. Vijay, for this opportunity. And Dr. Lallu has set the pace in, and she has spoken a lot about the impersonal environment that has happened, and how we are right now in the middle of all of it and dealing with it. So I'm just going to look at the personal effect of how communication has to be. And there are various challenges that we face in doing it. So is the screen visible for all? Yeah.
Yes, Dr. Kinsley, it's
visible. Yes. So when we are looking at what clearly the environment, the physical toll of the whole thing is quite shocking for the patient when they come. And what Dr. Lallu has already pointed out is the impersonal aspect of how the person is and what role they form. One of the things I strikingly find is the distance. And we maintain social distance quite a lot. And with the mask, it doesn't help in any way for the patient to understand. So when a person is talking with the N95 or a respirator or a surgical mask or in the spacesuit kind of hoodies, it is very, very difficult for the patient to understand. So in the beginning of a shift, a person may have all the energy to communicate, but as the shift goes on, they get tired, exhausted, and with tiring and exhaustion, you definitely will lose the energy behind how you're communicating. So a person who is a good communicator too can get exhausted. And people who are in the front need to have all the patience. And in the present pandemic situation, I don't think that is quite easy to come by. And people get irritated, they get frustrated with the situation, and a sheer physical exhaustion makes it so much difficult. The volume they need to speak and maintaining a particular tone so that it does not sound like shouting but still clear enough for the other person. So physical toll is something which really drags down on the healthcare worker as they work in these lines. And this is something we need to be aware of when we are communicating with our patients. And this is also one of the things that we have to be conscious about, because simple thing as an emergency is a very noisy place because people keep screaming at each other, even in the sense because there's so much of noise around. But with these additional filters on, that is the hazmat suits and the masks, it just makes it worse. So one of the important things we need is how to take care of ourselves when we communicate with our voice, our tone. Next thing is the exhaustion that comes in with these suits. People do get dehydrated quite a lot very easily, and that reduces our energy level even more, because to communicate you need to have that energy in you in the present situation to reach across, and that is something we need to definitely work on to make it happen. As ma'am said, identifying the role. I'm just reiterating this point because it's very, very important. In my hospital, we had a scenario where a patient came to the emergency, was seen there and told that they needed some additional things to be done, and they were moved from one zone to another zone. So one of the comments they made was like, anybody comes in any dress and says, do this, do that. So this is how people take you if you don't identify who you are. Are you a nurse? Are you a doctor? Are you a healthcare worker of any other sort? When these suits are worn, it's very difficult to identify who is who. And with these additional layers, it's very important that we have role identification become very, very clear. And this is all the more important between staff communication also, because we don't know who's the other staff behind the suit, and if you don't have a name on them, we'll be shouting, sister, doctor, please come, and everybody will think somebody will go, and ultimately nobody will come for help. So we need to have this identifying roles, a very important thing, because it establishes a rapport between the patient or who they are dealing with, and also an onus on the healthcare worker as to what is their responsibility and how they are reaching out to it. So identifying the role. This is the psychological toll that all healthcare workers go through. And communication is something that is very, very important. For a healthcare worker who's in the middle of all of the pandemic situation, there is life and death situation on a regular basis. But for the patient and the patient family who come in this situation, for them it is their most important time. And they don't take it well when we are not in the right frame of mind. And this causes a lot of anguish among them when they say that the healthcare worker was rude. Why are they rude? Because they had a long shift, they have seen deaths through the day, they have seen rude patients, and most importantly, they are also afraid of going through the disease themselves. So that is a huge psychological toll which affects how you communicate. Simple thing. Today, an Amazon delivery guy came to the house to deliver. He gave it and he just moved 2 feet back just to acknowledge, maintain distancing. For a minute, I was taken aback. Oh, he thought that I'm a healthcare worker, so he's maintaining distance. Same thing happens when we interact with our patients too. When we look at a patient and they say they have cough and cold, you like take one step back and say, oh, really? So it is something because we have it within us that we have our own psychological issue here because we are afraid. Though we are bravely doing our work, within us there is always a fear that what if we too fall ill? So we kind of react to things, and sometimes this can be very, very disturbing for the patient. So when they say the stigma behind a COVID suspect or a COVID patient, I think COVID patients are dealt better with. It's the COVID suspects who are actually facing the brunt because a lot of times they are the ones who come with symptoms and people are worried, oh, they may be COVID. Should we zone them first? We should move them. They're in the wrong place. So the way we communicate them, we are very, very anxious. Just to say, if a medicine OPD is there and a person comes there and says they had fever 1 week back, invariably they are turfed off to the fever clinic again. So these kind of things, the way we do it, you didn't tell this, why you couldn't tell this, can't you know that you're supposed to declare these things? So people get anxious. So that's one of the things we need to be conscious about, our psychological status and how we respond to it, because it really affects the way we communicate with the patients. So when it looked like situational responses, one of the things is most often people process information very differently. So, and when we need to communicate in this high stress doesn't have to be emergency, high stress doesn't have to be ICU. Right now, all of us have a pandemic, and that itself is a high stress situation. So we need to have our messages short, simple, and most importantly, we may have to repeat it. And under stress, people focus on the negatives more than the positives. And these positive messages, when we are talking, we should give them 3 times what we give our negative messages. So if you're going to counsel regarding a person who has been diagnosed with COVID-19, it's very important to tell that 80% of these patients are going to be very minimal symptoms, may not require hospitalization even. There are very few people who will require hospitalization, and some may become more sick. So when we are saying it, the focus is going to be on the positive messages of how the disease is going to be mild and minimal than on the you may land up in the ICU, because we are tuned to talking to people where we say we want to be safe, right? So even though he looks fine now, he may deteriorate, his oxygen level may go down, he may require an ICU, he may require to be ventilated. But instead we focus on the positives, but also tell the negatives. But how much of positives we give make the patient and their family feel a little better. So this is a very important thing when we deal with a situational response. And whenever we see a patient, there are a few things that we need to, since we are all going to be in some PPE or some form, or it's going to be over a phone, behind a counter, or through the electronic interface, we are not actually physically so close. So most importantly, be present when you're there with the patient. So you need to think, how am I feeling? How do I know who is this person? How do I feel about it? So make introductions. This is something very, very important. And many a time people assume, who else will come and see you other than a doctor? You think a housekeeping person is going to come and check your BP? It's going to be a nurse, of course. So please remember, don't assume. Make your introduction and explain your role. And identify a patient need. So we are used to assuming. Okay, we assume that the person is thinking the worst, or we may think that they are actually not so sick is their assumption. So we need to be very clear. Give them open-ended questions. Be ready to listen. And when we are listening, there are two things we have to be clear about when we are listening. One is the content, other one is the emotion behind it. So this is something which is a little difficult to handle because they are also behind a mask. But you can feel an emotion. The emotion is the way they talk, their voice, the tone, their pauses. All of them will help us to identify their emotion. And we need to respond to provide empathy. So how can we do empathy? So one of the most important thing about responding with empathy is, most importantly, acknowledging the emotion and validating it. So one of the common emotion we see is people are afraid. So we need to be aware if that is their emotion, acknowledge it. You look scared, and it's okay to be scared in this situation. So that brings about an empathy very easily, and this helps them to open up more, share more information, and make it clear. And then when it comes to us talking back as a healthcare worker, we need to be clear and concise. And whenever we give small bits of information, look for understanding, make sure they have understood it. And how do we do that? Despite all these layers that we wear, the eye still is visible. You may have a goggles, you may have a face shield, you may even have a hood, but you have eyes which still see through them. Even with the fogging that is there all around, when we breathe through these things, when we connect, remember the eyes speak the language. Okay, and we can do that, and it is possible. And as ma'am told, the smile can be seen through the eyes too. Same way, the emotion we convey is also seen through the eyes. That means they see the fear in us too. So we need to know that reassurance can be very much achieved when we make that eye contact. So this is just a mnemonic for you to look at it, check in, ask about their assumptions about COVID, lay out issues. Sometimes it's very important because most of the family is quarantined, they are elderly, children are not in the country. Those are a lot of issues to deal with. Motivate people to talk so that we know what needs to be handled. And always there is emotion, and this emotion is people may break down, people may get a little upset, they may get angry why the system is not helping. All of this can happen. And with the shift level working, it's very important to record these things so that the next person who comes doesn't have to repeat the whole thing, but take on from where you left so that it becomes easier for them to handle. Just a point to add on with an ICU communication. If you look at it, a patient with so many people around, it's not easy. And many a time, it is very, very impersonal. And with the lot of patients requiring ventilator, I'm not speaking about invasive ventilation. I'm talking about non-invasive, high-flow nasal oxygen, CPAP, all those kind of things. Those patients are pretty much awake and they can communicate. And these patients may be on it for some time. We have the cards which we can use to communicate. And many a time that is the only way the patient can reach out to us. So having a robust system where we can look at how communication can be established between the patient and the healthcare worker is very important that we have pre-made. In UK, there was one article where one anesthetist has written cards for 72 different topics which they can discuss with the patient, like the weather, cricket, and stuff like that. But some way where we can communicate, because these people are scared, they are afraid of what's happening around them, and many a time they are isolated with nobody for support. It's not easy because healthcare workers are also stretched, but this communication definitely helps. Even for intubated patients, the weaning period is pretty long, and many a time when during weaning they are not sedated too. So help them communicate. We have simple boards with pictures to show their physical things. I think we can expand it more. And one of the things with ICU communication I felt was the video interface using technology, where we can help the family to connect with the patient, know how the situation, because nobody is there as visitors, and that would also help. The whole scenario is so much impersonal with the environment, but deep down within our heart, we are all the same human interface in which we are working. And we also, as a healthcare worker, are in a lot of stress. And how we overcome it and become the heroes in the present situation to handle the communication brings us to rise above the challenge that we are facing. So these are things which I thought I could share with you, and I hope it makes a difference to you all. So,
Thanks, Lalu, and thanks, Kingsley. Fantastic presentation. You have already laid down a superb ground to get started. Some of it would be a repetition, but maybe it adds some value. So communication is difficult during this time, but I think what is expected from all of us as a healthcare worker is resilience, that we need to sort of understand that it is unprecedented, but need to bounce back. And that is what would be the key. So what I'm going to cover, part of it is already been covered also. I'll avoid repetition. Core communication skills, there are some barriers. And then between the healthcare workers, how do we reach out? And Dr. Kingsley has been the guiding force for communication. It's been over a decade that he has been taking such classes, and Dr. Charu, my wife, has been also one of his students, and is now taking sessions, and she has guided me for this presentation. So Buckman in 2002 mentioned that we will never meet everyone's expectation, but the effort we put in to our clinical communication does make an indelible impression. And I always take an example of a personal example of my wife, who had a post-ERCP pancreatitis, had a pericardial pleural effusion, burst abdomen, a multi-organ dysfunction, and we almost have lost her. She was there in ICU for almost 6 months, and but those difficult times, we still remember those resident doctors who had sat by her side when she was very low, and communicated, gave positive impressions, and just spoke to her. And many of the nurses, because she had thrombophlebitis, and it was only central line which was available, so just to get one vein, it would take close to 1.5 to 2 hours, but they'll keep communicating, they'll keep making her happy, and then reach out to her and just ask her to speak. And that was a fantastic impression, though it was very difficult time for all of us, but those are very cherishable moments during those difficult times. And if you do it badly, they may never forgive us, and that's why legality now drives clinical medicine. And I really detest that, because clinical medicine should be driven by evidence rather than because we want to save us from any legal thing, we start documenting. Because we want to say don't want to go the legal way, we take particular steps, and that's, I think, a bad way to practice clinical medicines. And if you do it well, they may never forget us, and that do happen. And Dr. Kingsley shares a lot of experience, and even Dr. Charu, that even if they are dying, they reach out and they say that you really took care, and it was very soothing, though it was a difficult moment for us, but you were there. This was one of the news articles which came about, unable to communicate is harming, and that is what we are feeling now, that it is becoming difficult, and the bystanders who are basically finding some solace with the other bystanders who are available are all missing. So they are unable to share. There are no bystanders. They are unable to share their feelings. The patients are isolated, and they are also completely left alone. And there are few difficult psychological issues. There are fear, there is anger, there is anxiety, there is isolation, not accepting the social confinement. There is fear of death, because unfortunately what comes out in the media is all about so many people, 25,000 cases, highest per day today, and then so many deaths. And uncertainty about the outcome, because everybody feels, and there are few people, senior people, educated people who have committed suicide because they thought that they are positive, and they were uncertain about the outcomes. And one of the doctor in a premier institution said that it is not just the treatment, but the words, expression, and body posture of a doctor that play an important role for comforting. And it is more true for during this COVID time. It's a humanitarian crisis. We are seeing the migration of workers. We are seeing unemployment. We are seeing a lot of anxiety, depression. We are seeing, we don't know, all mathematical modelings are failing, and we don't know where this crisis will end. And we are supposed to work on basis of ICMR categorization, where mild to moderate are still manageable, but it becomes challenging for B2 and C category of patients to communicate them. The expectation is a very warm, encouraging doctor who would come out each day, and the healthcare worker, but it is the present PPE scenario which makes it difficult. Now, it is also said, it came in JAMA, that we interrupt every 23 seconds when patient is mentioning about their history. We do not include 50% of what patient have said, and that is because we don't listen to what the basically patient is mentioning. We don't inform in less than 1 minute the prescriptions. So we are very tied up. We know what the patient is about to say. Rather than listening the full story, we start writing the prescriptions, and we do intimidate. The white collar syndrome white coat syndrome works, where we intimidate people, and there is a fear factor. So they may come with 10 questions, but by the time they're meeting the doctor or the nurse, they're left with 2 because they feel intimidated. And so the shared decision making for a proper communication gets lost. This is one of the work which we are doing right now with Imperial College and University of Cape Town, where this is in antibiotic stewardship, where we are using a tool called sociogram, and we are shadowing the doctor. And what we see is there is a senior surgeon who comes for the round, gets most of his information from the senior resident doctor, and all the assistant associate professors are behind them, and they are mute spectators. There is very little interaction which happens with the patient, and maximal information is retrieved from carer, and some of it the nurse participates about the previous night's issue where the nurse was not present. And when we saw it with respect to antibiotic stewardship and infection prevention, there is no discussion. So it's a Western concept where we say it's a patient-centric hospital, but in India it is a very much carer-centric hospital. Now in a COVID time, this gentleman is missing, and this whole paraphernalia is also missing. And that is why the communication is becoming very difficult. We use this for each doctor and to change behavior, because we also realize that training is not helping anymore. Training along with the behavior change will help. And so we reach out to them with this diagram and say, this is how you have behaved today. And some of the expectations are still not met. Some of the core communication skills, Dr. Kingsley has covered some of them. There is an empathy which is expected out of every healthcare worker. So sympathy is you feel sorry for the patient, or when you're speaking to the attendant. Empathy is that you know where the suffering lies. So you know that the patient has cancer and he's worried about his death because cancer is a bad word. And compassion is removing that suffering, and that is where we want very compassionate and empathetic healthcare worker. It is difficult during this COVID time, but nevertheless it is what is expected. There is a positive regard, and I really like this statement or the word being used. Positive regard for the patient is extremely essential. So there is nothing which happens even if the patient is a VIP patient, or he's economically poor patient, or a rich patient, or he has very many comorbidities, he's almost dying, or he is doing well, but he is very anxious, and he has, every time you reach out to his room, he has 10 questions. So those negative, you don't reach out to the patient with those negative feelings. You always reach out with a positive information, positive regard, and make the patient very much comfortable. Honesty and confidentiality is it's almost a done thing. But what we generally feel is we don't empower the patient. We tell them that there are you need knee replacement, so there are very many implants which are available. It's up to you. You can also get an injection done, and which may work for 6 months. There are ceramic on ceramic, there is titanium, there are national implants, there are international implants, and there is definitely a conservative therapy. And if you are in Kerala, there is definitely an Ayurveda treatment. So what we don't do is a shared decision making or empower the patient. So we give them a bouquet and sometimes statistics with this bouquet, and there is where the patient gets extremely confused. So do we tell them that if it was my father, I would have chosen an implant which is an FDA approved, and this is what it is, and I would since there is a good quality of life for another 10 to 15 years, I would go for it. So can we empower them to take some decisions rather than giving them a bouquet? Listening is adequately covered by both Lallu and Kingsley, because it's their part of story which we need to hear. Creating an environment is also extremely important. Sitting down, giving a privacy, providing that kind of a comfort, removing any physical objects which are there. So a good briefing room would be that you have a sofa set arrangement, there is no table and chair, and there is no barricade in between the patient and the bystander, or the doctor and the bystander, or the patient. And there is where you reach out to the to those who you need to communicate. I also took during this COVID time, I took my wife for one of her ailments, and she was being seen in the corridor, and the attendants are not allowed. And so if you need to reach out, it is not there. She's speaking with N95 mask. The other gentleman, who is the doctor, who is a senior associate consultant, is having a visor and a mask. So what he is uttering is unable, the patient is unable to hear. And at times there is this repetitive communication which is happening. So it is definitely a difficult time, but nevertheless, we need to be very, very patient. What is very, very bothersome is the hurried conversation which happens because you have an OPD or you need to rush, which happens on the corridor. And that is where you communicate wrongly or communicate incompletely. And patients are always then looking out for more information through medical social worker and the nursing staff. And they call more and more relatives because they are so unsure that we don't know what patient doctor said, but he said that he's serious. And many a times now mobile is a big interruption. So it would be appropriate whenever you are having a difficult communication conversation to avoid all these interruptions. There are many kinds of communication, but non-verbal is 70%. And so we think that verbal part is the most important or key communication skill, but it's non-verbal and para-verbal. And if we have skilled this art, I think we become a better communicator. And what is important is active listening. And this is what we have felt that in my hospital, the head of department of neurology is such a brilliant active listener that moment you get into his room, the patients and the bystanders, they are always coming out satisfied because he is giving you the time. He's been always nodding. He has always have the facial expression. He has maintained an eye contact. He maintained that posture that he is concerned. And he gets up, opens the door when they come in. He gets up, opens the door when they go out, so that you have answered all the question and you go out satisfied. And that is what is important. This is one of the booths which I saw in University of Michigan, where every bit of communication which happens on the day is mentioned on the on the board, who all are treating you on that particular shift. What are the additional care providers which needs to come in, like dietitian, respiratory therapist, echo technicians, or things like that. What is the goal of care which for that particular day? What are the schedule, if it is an MRI, if it is a cardiologist consultation, or is a physical medicine and rehab who needs to visit. Any family contact information is there, so that you're not always worried whom you're reaching out to, and patient and family questions and comments are also addressed, so that there is no repetitiveness. And tone and pace is already been covered by Dr. Kingsley. Verbal communication is only 10%, so we can be rest assured that it is more of non-verbal and paraverbal which is important. Open questions, which is the key, and most of it is covered. But what we need to avoid is medical jargon. And I keep remembering this particular incident where a gastromedicine resident, he sent a patient for an MRI and he wrote on a requisition slip APDWGOO, and the consultant on the other side of radiology asked what this particular thing means, and he was very wild, and he said that it is acid peptic disease with gastric outlet obstruction. The resident of radiology got so wild, and he sent the patient back with another abbreviation, said MOO, and the gastromedicine doctor said what this means, and he said machine is out of order and he won't be able to do the MRI. Unfortunately, there are huge jargons which we use during our practice, and we speak the same language to the patient, and that should be avoided. Since we are so poor and we don't want to spend time, so we give hope. So as soon as you get out of the ICU, you say that we have changed the antibiotic, we'll watch for 48 hours. So you buy time just because you don't want to do the difficult conversation, or you don't want to break the bad news. So we say that today I'm going to get an MRI done for this patient, so we'll see. So we give premature reassurance and hope, and that is where we always also go wrong. We need to pick up on the verbal cues which the patient and the bystanders say. That we need to watch their body language. Basically, we need to understand, because if they are saying that I was worried and I didn't sleep yesterday, but I also had nausea and vomiting, as medical professional, we pick up physical symptoms, nausea and vomiting, and we give medications for that, but we don't get into the details of why the patient was worried and why he didn't sleep, or maybe just give an additional the sedative. So we need to be, or many a times we just label the patient that he is anxious or depressed and get a psychiatric consultation. So there are lots of verbal cues which we need to watch for. We need to validate their feelings. We need to paraphrase. You need to speak it out in a read back in different forms, so that you ensure that what you have understood is what they are mentioning. A patient may say that he has discomfort, he has nausea, vomiting, he has pain, he is slurring, and when you hear him out, you need to summarize and prioritize. So you said all of this, but pain is your main concern, and you also said that slurring and nausea and vomiting. So you prioritize so that the patient is reassured that his summary, his story has been read well or understood well. Generally what happens is the patient has complained, and 10 times he or she escalates the complaint and escalates to the bystander. But bystander feels so scared to always reach out to the doctor or to the nursing staff, because he or she knows that they will be shouted at. So he provides comfort to the patient 3 times. And then from here, they move out to the nursing staff. Nursing staff is also very busy. So they hear some of it. They say that it is repetitive, and only 2 times they reach out to the doctor. And this resident doctor reaches out only 1 time to the senior, who acts upon 10 times which the complaint the patient has escalated. So that is where I think we really go wrong, and we don't empower the patient, and we don't give that comfort that we are there and you can reach out anytime, so that they feel secure. Doctor-patient relationship is extremely critical, and it varies from the satisfaction, the team, the safety, the chances for litigation and compliances with respect to the orders which has been mentioned, during intraoperative, post-op, pre-op, or discharge. Finance is one area where, again, there is huge communication gaps and there is mistrust and litigation, and we get a bad bill. To answer that, it would be important to do a daily billing, have SMS alerts so that there is adequate information which goes on. We need to be very honest with our package information, because we see sometimes it is an activity-based costing and sometimes it is along with the TPA and then the rest is all paid by the patient. It would be good to take a consent on what they have agreed upon and keep explaining time to time what is important. There are lots of social barriers, and I'll not get into it because it has already been dealt with. So Kubler-Ross model is a 5-stage of grief, and that most of the patients will undergo the same phenomena. If you say that if you have COVID-19, there is the phase 1 is denial. And they always ask, why me? And it may not be true, because you may fall into 69% positivity or 39% false positive, and you keep questioning the whole scenario. And because you have turned out positive and there is either a quarantining or admission, there is anger. And then you bargain, can you stay at home, or you need to be, because you can watch your symptoms and there is an oxygen concentrator, you bargain. And you realize that it's a long drawn battle. At times you get depressed during the whole journey, and it takes time for a gentleman or any other patient or bystanders to accept. So everybody more or less goes through this emotional response. And I think as a healthcare provider, we need to be completely wary of this, completely accept this, and there may not be some other response. We assume a lot of things. We assume that we are good communicator. We assume that we have already communicated, and on the basis of assumption, many a times the importance of the feedback or what we need to tell the patient and the bystander is left. The human touch is important, but it would vary from country to country or from various geography. But definitely this is one area which is very essential, but in COVID times it is difficult. Regular briefing is extremely important. You realize that in state of Kerala, who's done so well. You realize that in New Zealand, who's corona-free, that they have been either using social media or other platforms where they have been regularly in touch. So post-traumatic stress syndrome is a pandemic which is there. Every healthcare worker is fatigued, and they're asking when is this going to end, because first 2 months they were very excited and they wanted to win that battle and they wanted to serve, but then it is getting high on nerves. So there needs to be many mechanisms where we need to give them either indulge in the hobby, me and we time, staying connected, huddle meeting, or having a healthy team relationship would be important. I'll end my presentation with my take on doctor-nurse communication. Though I am very fond of the nursing staff and they are most obedient healthcare worker, which we see in our setting, but what generally happens is the gap. And what is the gap is because a pediatric cardiologist does his MBBS, MD, DM, he does a fellowship, he's extremely well trained, he gets an experience at a premier hospital, he becomes a head of department, he becomes a national faculty, he becomes an international faculty, he does a lot of education, and so he's a very, very well renowned and extremely skilled and trained. And on the contrary, we get a nurse who's a graduate, who after BSc applies for a job, he gets recruited, gets challenged at the committee, who gives all kinds of dirty looks to this poor meek girl who appears for an interview. She gets selected, and since she's very joyous, she's very relieved, but as soon as she is selected, she gets into an ICU because there are 5 nursing staff who have left. So she's immediately thrown into an ICU where there are alarms and beeps and there are monitors, and she has absolutely no clue. And when the doctor, who's so very well skilled, trained, his expectation is different. And this poor girl is unable to match that expectation. And that is where our relationship and communication breaks. And that is where, as a doctor, a positive regard to your nursing staff and paramedical staff is important. We also need to build a culture of interprofessional communication, because it is just not a doctor, a surgeon who comes and takes the shot, or a critical care physician. It is a group of doctors, which also includes a clinical pharmacist, a nursing staff, a nursing educator, a dietitian, a therapist, who all take, a surgeon and the physicians, who all take rounds together and build a very healthy atmosphere so that everybody learns. And then there needs to be some certified training course. But what is key is always keep having a huddle meeting and understand. This is what University of Michigan does. They have a big board in each ward where they say that these are the unit news. The round takes place here, other than after you get out of the patient room. These are the weekly trends of your indicator. These are the matrices. These are some of the problems, and these are the ideas, and you empower them to come out with more ideas to solve situations, and the patients get better. And we need to do more of this and keep a very healthy relationship between the healthcare providers and provide good communication even this difficult times. Thank you very much. Thank you, Dr. Vijay Agarwal, sir, CAHO, and Lallu, and Kingsley. It has been a fantastic learning experience being a panelist with you.
Fantastic presentations on the kind of problems that we are having in today's day. If you have addressed this is really superb. And it was evident from the fact that virtually, after every presentation, there has been a kind of huge congratulatory messages to each of the presentations, which is not a normal thing. It comes mainly towards the end of the presentations, and here it's kind of going on. And therefore, so let's hear if there are any issues. The only thing which I can try and ask you guys and give your inputs, maybe that should we not be using, I would say again, microphones at appropriate places to, I would say, reduce the stress on your vocal cords or something, even maybe a low volume ones. I think all of it has been already covered. The only thing I thought was that maybe the use of scripted kind of communication, do you feel? So maybe Sanjeev, I think.
Yeah. No, I think it is extremely important, and that script.
Sanjeev, what is your?
Yeah. No, I think what you are saying is extremely relevant, that especially I think we should not lose this opportunity during the COVID time to script it. Because I think Kingsley and Dr. Badri has been doing it. They have the script ready, but does each hospital has it? No. So we need to have that script ready. We need to train everybody in this communication classes. Medical Council of India has now made it mandatory with CBME coming in, that research methodology, communication, and ethics is now a mandatory thing with each colleges. And I presume that more and more undergraduates and postgraduates will get trained in this. But it is key. And during COVID time, we should not lose this opportunity, and at least get the communication skills training done for each healthcare worker, and more so for the senior doctors. I think that would be important.
Dr. Kingsley, I would say that we must identify the, I would say, the interactions where the script can be very useful. So whether a person, when he's coming, like you said, the guard who was, ready to put a gun on your head for your temperature or what, but there could be some kind of a scripted, because that person, his own, you cannot expect him to be an extremely polite or something, but I think if you train him with some very proper words, I think he may do the job. And similarly, when a patient arrives in the ward for admission, who should say what? Just like I think the air hostesses are trained that every time you get onto an aeroplane, you hear a stereotyped similar thing. And anytime when they are thrown into uncharted communication, you find gaps in that communication. So, Dr. Kingsley.
When it comes to communication at various stages, so one of the things is at the first point of contact, that is security or a counter or an information desk, it's very easy to have a script on what are the frequently spoken things there, directions, information about availability, where to go. All of those things can be very well scripted. Same can be done for the nursing also. Like if they are going to have a ward orientation, a script for what are the things that they are going to do, an initial assessment where they are doing, what are the things to be conveyed, and most importantly, like even a small talk also, like while checking a BP, what are the things that they can talk, what are the things that so that would make it more easy for the newly joining people or the people who are just experiencing. But as they go, that will evolve. But it's a good thing where we can help people to feel more confident that they can actually talk and establish a rapport. And for the patient, it will be a good experience that they are not having random answers and not getting irritated responses, because one of the things about scripted communication is you can actually loop it. So it's like a broken record sometimes where we may have to repeat the same. I'm so sorry, I wouldn't be able to help you at this time, but we will look at it, we will get back to you. Or the present thing is bed crisis. So I'm really sorry, our critical care beds are full at this moment. We will let you know, or can I take your number? So it becomes a standard thing, and we can use it like a broken record technique where we can take down these details, and that also can be scripted. So this empowers soft skill techniques for the person who is interacting, very importantly at information giving or receiving level at any place, be it the ward, emergency, or even just the telephone exchange point where they are doing this.
Yeah, Lallu, you like to add something?
Yeah, particularly with the swabbing, I feel it's very important to have that as a scripted communication, because most often, the communication is interrupted there. It is not full. So typically, I've now seen my friends, many of them, our own colleagues who have gone through this, and they being healthcare professionals, doctors, nurses themselves are very, very scared to go through the swabbing process. So it's extremely important that it is scripted and we don't miss out the steps, so that, and again, sir, there is a danger to scripting also. It can become like a recorded, that personal touch shouldn't get lost as well. So I think more and more we
I'm
become
talking. I
think your voice is breaking.
We are unable to hear it, sir. It is, audio is not clear.
Importance to the okay.
So your audio is not clear, sir.
What I'm saying is that in normal circumstance, am I audible now?
Yeah,
better.
Let me remove this. And is it audible now?
Yeah, it is clear.
So saying that under normal circumstances, we have always debated, because the healthcare workers always want independence, and you don't want to be like in a robotic way of trying to say and do the same things. But what we feel that under the present circumstances, it is like lesser of the two evils. And I feel like what you absolutely said, there is no way that somebody is going to tell you the steps of taking swab and all that. It's important to be available on the site place where this is being taken. So points where scripts can be shown to talk about this. He can be told as to what he should cover in his communication.
Exactly.
But I think kind of people at the level of your guard, or the people in an emergency technician or a nurse who are recently or junior level staff, they need to be told some of that thing, I think for better or effective communication.
Absolutely.
So on the whole, I don't see actually any questions. Will it be better if the communication is customized? So anyway, we are talking about that customized communication. Can I get the PPT of the webinar? Yes, the webinar will be available at CAHO.in almost by tomorrow or day after at our resource center. So it will be available to you. And anything else? In your roundup things?
Your voice is breaking in between, sir.
Something, or else I think it has been a wonderful presentation and something that people who have missed, they need to kind of go back and listen to it again.
Yeah. Thank you. Thank you very much, sir.
Yeah, Sanjeev, you were saying something.
No, I think it is CAHO, I think, gives a fantastic opportunity, and I'd like to congratulate you and Lallu for doing all the hard work behind the scene, and especially Sakshi, who gets all the organization done. So you provide a superb platform, and I think this communication is also extremely important. My last word would be that if you can, during this COVID time, if you can be humane in our approach and also express that humanity when we are seeing this patient, it will be very important. What we generally see is that we are all protecting ourselves as a healthcare worker because we are so scared, and then sometimes we miss those communication link, which is important. So that humaneness, if we can maintain, that would be, I think, essential. But it is superb to hear Kingsley and Lallu, and it's been a fantastic opportunity. Thank you once again.
Thank you. It's been a wonderful team that I have been a part of. So thank you for the opportunity. As Dr. Sanjay said, the humanness, and as Dr. Lallu said, let's make the impersonal environment more personal. So I think we can make this pandemic, this too shall pass, in a wonderful way and connect with people in a better way. Thank you.
Thank you, Sanjeev sir and Kingsley. It's been a wonderful experience with the two of you, the two veterans. Thank you for that. And as Kingsley said, definitely this too shall pass. Let's wait for the good day to come. Thanks.
Thank you. Perfect. Have a good day.
Good day.